Some housekeeping rules today is, first of all, if you would silence your phone, I would really appreciate it. This program is being recorded today, so if you want to by the FBI, you want to stay behind the cameras. The restrooms, don't laugh, that happened to me once, okay? Or if you're in protective custody, it's good that you're not photographed here. Restrooms are to the far left. If there's overflow, there's some more down the hall. I believe coming and going through the hall could be challenging. As you know, there's a great deal of security getting in here today. We will break for lunch halfway through, and we will have questions and answers after each physician. And you have some paper and pens if you'd like to take notes. I see you're enjoying our latest issue of our Lupus magazine. And if there's any fellow Lupians in here that would like to share their story, we would welcome sharing it with the rest of our population. I want to give a great deal of thank you to my guy. Suzanne's always got a guy, but this is one of the best ones I've had in a long time. Alex is my, we call him our damn guy. He's our digital asset manager. And I want to say kudos for him to putting this all together. And in the new digital world we live in, he has become an incredible asset to our organization. So thank you, Alex. Adrienne, who's my left arm. Adrienne, there she is over there. She's also a fellow Lupian, as beautiful as she is. She's in charge of all the different grant projects that we have going on. We have Rita in the corner. Rita, are you back there? She's kind of short, so Rita is there. Rita is our head patient navigator. She is a nurse, so at any given time, if you need to have a conversation with her, feel free to call the office and she'll rise. So we're going to get going here this morning. I do want to thank all the doctors who stepped up today and provided their precious gift of time. We are very, very grateful. And for the beautiful facilities here at Metro. This is the first time we're back since the remodeling has been done. And of course, GSK, who is one of our leading sponsors. We have Lee over in the other room. Thank you for coming in. Thank you for the dollars. We couldn't have done this without you. They've been a wonderful partnership with us for the past several years. We have Chad from, he must be sitting because he's really tall. There he is. Chad is from Arena Pharmaceuticals. Also has been a wonderful supporter, especially of our patient navigator program and this program as well. In the recent years, we have been finally blessed with new medications. And so now we have pharmaceutical representatives that have risen to help us with all the programs that we have in trying to give you all better quality of life. So thank you to you. I didn't think I'd live this long to see these new drugs. So I'm very excited to see what tomorrow even brings. Okay. Did I do something wrong already? Nope.
The slides.
So our first speaker is Dr. Antonelli. I just learned that she can outspeak me in Italian. She is from the university. Dr. Antonelli is, oh, I'm sorry, did I do this wrong? Pardon me, I'm already messing up. Here, I got you. Okay.
Where did it go?
It went away. Okay. She's a board certified staff rheumatologist here at the Division of Rheumatology. She completed residency and fellowship and served as chief resident. She's also assistant professor of medicine at Case Western Reserve and is very passionate about training fellows and residents. She has a special interest in lupus, and her presentation today will focus on blood work because we all know we go to the chart and try to figure it out and we need interpretation. Let's give a warm welcome to Dr. Antonelli.
Thank you, Suzanne. And thank you, Dr. Ballou, for inviting me today. So as Suzanne mentioned, I'll be covering laboratory tests that are involved in lupus, something that I get a lot of questions about. That we're going to focus today on a couple of different aspects of laboratory tests. All right, so a 30,000 foot overview. Why do we do laboratory tests as clinicians? I'm going to focus first on a couple of blood tests that, laboratory tests that are for confirmation of diagnosis based on clinical suspicion. Then we'll move on to several disease activity blood tests, as well as monitoring medication concerns. So the first test, the very famous or infamous screening test, the ANA, the anti-nuclear antibody. This is a test that often clinicians do to assist in figuring out if the disease is present. So if you look at the bottom picture, we've got a big purple circle that is supposed to represent all of the lupus patients, all of the lupus patients who have a positive ANA. The little yellow dot, each of these represents a lupus patient. So it is extremely rare for a lupus patient to have a negative ANA. Okay, if you look at the purple, this is all the lupus patients who have the positive ANA. So we only have one sitting outside the box. Okay, this means if we have a negative ANA, we generally mean that there's no lupus, but there is that rare situation where we can have lupus. This is a test that is generally not repeated. This is only used in the setting where a clinician is going to make that diagnosis. Now, this is a tricky test because if we look back through the past 20, 30 years, this test was done in several different ways. In the old days, there used to be done in a particular way where there was a lot of time intensity. The pathologist, the technician had to do a lot of specialized testing where they were what's called dilutions. So sometimes you'll see the test reported as something that gives a number like 1 to 320, 1:640, 1:1000 something, right? The higher the second number, the higher the positivity. Usually it's the more likely that the clinician should be suspicious of what's going on. The newer testing is usually much more simplified. It's done in a cheaper way, sort of a less, I don't want to say less specialized, but it's a less intensive way of doing it, where usually we'll get a positive or a negative, and sometimes you'll see a number 1 to 9. The higher the number, the more positive. Like I said, these are tests that are generally not repeated. However, they're done at the beginning of the disease course. On the top picture, you'll see little fancy green pictures, little fancy green highlights. This is something that sometimes the ANA testing will report a pattern, and that's in the older style of doing the ANA, where the pathologist, that's the special lab technician, who looks down and will see where those antibodies fall. And some of those patterns will relate to a certain type of connective tissue disease, may it be lupus or other types of connective tissue disease. The bottom is a different representation. That's the newer testing, just little beads. It's either positive or negative. Now, there are other antibodies other than that ANA. These are generally much more specific blood tests, so not every lupus patient will have these. And some examples of these would be anti-Smith or anti-SSA, anti-RNP, anti-double-stranded DNA, or anti-dsDNA. Now, compared to the previous picture with the purple circle, we've got a purple circle here representing all the positive ANAs who have lupus. All the little yellow dots are each lupus patient. Now, when we look over here, we have more specific tests. So each of those specific tests would be that purple circle. So we have a lot of lupus patients outside that purple circle. So that means that you can have lupus, but you don't necessarily have all of those other antibodies. Now, generally, these antibody blood tests are not repeated, except for the anti-double-stranded DNA, which is the one that is sometimes followed for a lupus patient to follow the disease course, in particular for lupus kidney disease. Now we move on to some laboratory tests that are focusing on lupus disease activity, and you'll have noticed probably in some of the blood tests are C3 or C4, and these are a type of complement. Complement is a type of protein in the immune system, and so these components in lupus, as well as some other situations like infections, are quote unquote used up. So if these proteins are used up, the levels will show low levels. And so if we have low levels in a patient with lupus, the clinician might be thinking, is the lupus disease activity high? The next disease activity measure is something called the erythrocyte sedimentation rate. Erythrocyte is another word for the red blood cell. That's the type of oxygen carrying cell. So this is an older test that is also in some situations called the Westgren, and that's just a discrepancy on the type of assay that's used. That means they use a different kind of tube. This is a non-specific inflammation marker. So the way they do this one is they take a tiny little tube, it's only real short, they put some blood in it and they let it sit on the counter for an hour. And they say if there's some inflammation in there, scientists have found that the inflammation, the coagulation factors will stack the red blood cells and they'll fall. And at the end of that hour, there will be a little stack sitting. Now the height of that stack will reflect the amount of inflammation. So the higher the number, the higher the ESR, that's a suggestive of higher inflammation levels. There are some also other things that can affect this. For example, if a person has anemia or low red blood cells, low oxygen carrying cells, as well as if a person has kidney disease, if a person is pregnant, as well as with age. Similarly, another inflammation blood test called the C-reactive protein, or CRP. This is another non-specific inflammation marker that that rheumatologists and clinicians look at to evaluate inflammation. Now this guy, instead of kind of looking at a whole bunch of different inflammation particles, this is one specific particle, one specific protein. This protein is cranked out by the liver. It goes up very rapidly within several hours and then peaks within 1 or 2 days and goes down within a week. As I mentioned, this is non-specific, so anything can make this go up. Heart attack, an infection, lupus, stubbing your toe, cutting your finger, etc. However, normal blood levels of CRP does not mean no inflammation. And that can be tricky because I just told you it's a marker of inflammation, but there are many things that affect the inflammation cascades in the body. There's also something that you might have heard about called high sensitivity CRP, or you might see listed as HS CRP, and that's just a fancy specialized assay that is usually done in the setting of cardiology or looking at heart and risk factors for heart attacks. The next test is called the urinalysis, abbreviated as the UA, and this evaluates the urinary system. This laboratory test can evaluate for infections, can evaluate if there's blood in the urine, if there's kidney problems. And in the setting of lupus, this is in particular important to see if the lupus is affecting the kidneys. When we're looking at a lupus patient and looking at a urinalysis, we're specifically looking for protein as well as blood or RBCs. Another test that's often ordered with the urinalysis is called the urine spot total protein ratio, and that is basically a measure of how much protein is actually in the urine, how much protein is being quote unquote let go by the kidneys, which is basically how we evaluate if there's damage or inflammation from whatever disease. Now we're moving on to, this is the cusp of disease activity measure as well as monitoring for drug problems. So the complete blood count, and I have in parentheses with differential. Sometimes this is abbreviated with CBC-D or CBC alone. This evaluates the different blood cell lines in the body. The three important blood lines are the WBCs, or the white blood cells. These are infection fighting cells. And when we talk about the differential, this is what we're talking about. We're saying that there's many different types of WBCs, or infection fighting cells. And so sometimes it's confusing, but when I look at the CBC-D and I look at the differential on the types like the lymphocytes or the neutrophils, I think about a pizza. And I say there's a big piece of pizza that are lymphocytes, and there's a smaller piece of pizza that are neutrophils, but you always have a full piece of pizza. right? Or a full pizza pie rather. And that's the confusing part, looking at those, sometimes looking at those complete blood counts and seeing that one cell line is on the low side and one is on the high side. And lupus can do various things, making one cell line go low. The next important line of blood cells are the red blood cells, or the oxygen carrying cells. We generally don't look at the number itself. We look at the hemoglobin, or I don't have it listed here, but hematocrit. And those are two different measures in the complete blood count, where clinicians will evaluate if there's an anemia or if cells are either being lost or not being produced in the bone marrow, or if they're being destroyed in the bloodstream. And the third important blood cell line is the platelets. And these aren't cells at all. They're just small fragments of cells that are important in forming a clot. So if you cut your finger, we don't want you to bleed to death. So your body is smart and produces a little clot by putting a bunch of little platelets to plug up the hole. Now, lupus patients might have low cell lines, any of these, or all of them. So you might find low WBCs, low hemoglobin, or low platelets, depending on the disease state. As I mentioned, this is also important for monitoring lupus medications, because many of the medications can cause problems in any of these cell lines. The next important laboratory test is the basic metabolic profile, also known as the BMP. This evaluates the kidney function and electrolytes. So when we're focusing on the kidneys, the two important numbers are the creatinine, or the B, and the BUN. And these are basically muscle proteins that are regularly turned over in the body and basically cleared out through the kidneys. And so the higher the number of the creatinine and the BUN, the less the kidney function. If you skip down 2 lines, the GFR, this is actually a calculation or a measure of the kidney function as well. And the other important parts of the basic metabolic profile are things like the potassium, the sodium, and the chloride. And these are important electrolytes that your body uses to function, letting nerves function, letting muscles function. And then there's the bicarb, also sometimes listed as CO2. And this is basically a buffer that changes the acidity within your blood. The next important laboratory test is the liver function test, also known as the LFTs. Now there's 3 important pieces. The first piece is the protein and the albumin. These are important proteins in the blood. And here we actually sneak in a little bit of an inflammation marker. So the albumin, even though it's a protein floating around in the blood, it can go low if there's high inflammation in the body. The AST and ALT, these are liver enzymes. And so if there's inflammation or infection or scarring, like cirrhosis in the liver, these numbers can go up. And then the third important piece of the LFTs are called the bilirubin. And these are breakdown products from when the body turns over blood cells. These are important in measuring lupus medication problems. And sometimes you'll see in some laboratories a CMP, or a comprehensive metabolic profile, and that's just the BMP plus the LFTs all together in one panel. The last laboratory test today is the creatinine phosphokinase. This is not done typically. However, in some situations when a clinician is nervous or suspecting that there's muscle inflammation from lupus, this number is checked. This is basically a measure of muscle. So a person who has a lot of inflammation in the muscle, or something called myositis, will have an elevated CPK. This is sometimes checked with a different number called aldolase, which both looking together can help a clinician decide if there's myositis or muscle inflammation. And that's all I got. Absolutely. Are there questions here or? Mm-hmm.
You get the sclerosis purely because that number of the, what was it, the
AST and ALT. So cirrhosis can happen. Cirrhosis just means scarring of the liver. And that can be from many, many things. It can be from alcohol, can be from infection, can be from medications. when clinicians are looking at that number, we're thinking that as that number goes up, there's more and more inflammation. We wouldn't make that diagnosis of cirrhosis based on the number itself. Usually there's some imaging, either an ultrasound, sometimes there's an MRI or a CAT scan, and even sometimes there's a biopsy where a radiologist has to go in between the ribs and take a small sample. But the higher the number, it's basically more inflammation in the liver. That's okay.
Also with the infections that we can get.
Okay. It'll come to you. If there's any other questions, and then I can come back. Go ahead.
Going back to the ANA
Mhm.
numbers, you said the old test was like 1 and 640.
Exactly.
1,000.
Yep.
Or whatever,
Mhm.
or 1 and 400 something or whatever. So the higher the second number
Mhm.
means
The more positive the test, the more convinced we are that there is ANA floating around. So the lower numbers, sometimes you'll see like a low number 1 to 40 or 1 to 80, and that's like a light gray. I'm like, it's sort of positive. It doesn't mean anything. Remember, these are tests that help confirm a diagnosis. The diagnosis of lupus is not made by the ANA test. It's made by a clinician with the patient, looking at the symptoms, looking at all the other blood tests, and saying, in the right setting, do we have enough check boxes? Check, 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 right? But when we get those very high numbers, my suspicion goes up. My red flag is like, I shouldn't forget.
so I asked that because like on the slide it said something about there can be a confusion with the numbers and you could be diagnosed with Sjogren's.
I'm sorry if the slide was confusing. I'm going to go back. So the positive ANA test can be seen in lupus as well as many other diseases. And when we have that number where we call a dilution, 1 to 320, we get a pattern like that. I don't know is it gonna let me do this or probably, okay. The colors up at the top, certain patterns are associated with certain conditions like Sjogren's or lupus or scleroderma, right? That's the old testing. In the new testing, we have a positive ANA, and then you have those more specific tests, positive SSA. Now I think Sjogren's. But all of that has to reflect what the patient is talking about, right? I have dry mouth, I have dry eyes, I have swollen glands, I'm fatigued. This definitely sounds like it could be Sjogren's, but it also could be lupus. We have to keep an open mind. Does that make sense?
It does. I was tested a really long time ago and they
Mhm.
Sjogren's, but they never ruled out lupus. So.
Yeah, Sjogren's and lupus there's a overlap, and I think that's a very common confusion that sometimes it's very difficult in the moment to say, is this or is this that? Sometimes I say we need time. We need to let time tell, right? Sometimes with more time, things become clearer. Other questions? Go ahead. So bilirubin is a blood cell breakdown product. So if the body, if there's lupus or other conditions that are breaking down red blood cells, the bilirubin can go up. Some medications can make the bilirubin go up. I suppose we could think about it as a type of inflammation, but we don't think about it as an inflammation marker like that ESR or CRP. Okay. There was one around the corner. Yep.
I was diagnosed with Sjogren's way before I was diagnosed with lupus, and I think that there was a thought that maybe it was there, but it never really showed up until like years later. How often does that happen?
Sjogren's can be a condition by itself, and Sjogren's is very common with lupus. So I would say that Sjogren's and lupus overlap, especially when it's a sort of a question of mild lupus, is very common. I make that sort of diagnosis all the time where I say, is this mild lupus versus Sjogren's? And sometimes we just need time to tell. Suzanne. Oh, speckled is one of those. I shouldn't have put those pictures. I made it confusing, right? It means that those green pictures in the top right, it means the pattern of when the pathologist looks down at those ANA are speckled across the cell, like a Dalmatian dog, right? Like it's polka dots, and it's associated with one of those conditions, right? They basically don't even report them anymore, but I was mentioning it because I know that when we look at older tests, sometimes it's still reported.
This is just someone that asked me about
Mhm. Yes.
C3 and C4, is
Mhm.
that, you have the CH50 in front of
Yes.
you. The CH50, is that basically C3 and C4, or is that a separate test?
So there are many components of complement. CH50 is assessing all the whole complement system together. So it's actually looking for a complement deficiency, which can put you at risk for lupus. So it's not typically checked as like the other ones. C3 and C4 are very commonly, most lupusologists are going to be looking to see if C3 and C4 are low. CH50, I probably shouldn't have put it in there, that if it was ever checked, it's usually a clinician thinking, is there a complement deficiency that could have put this person at risk, in which case they might always have a low certain type of complement. Okay.
That answered my question
Yeah.
perfectly. I always see 3 CH4 on my test, but never CH50.
Yeah.
Okay,
Yep.
makes sense. Thank you.
Okay.
What's the difference between mixed connective tissue disease and?
So mixed connective tissue disease is its own basket. Sjogren's, lupus, mixed connective tissue disease. It's one of the sort of newer defined connective tissue diseases, but to have mixed connective tissue disease, you often have features of lupus, scleroderma, myositis, rheumatoid, and Sjogren's. So yeah, I like to tell my trainees, clinicians are often a lumper or a splitter, and I'm a lumper. Is it a rheumatologic condition? It could be this basket or this basket. They're all pretty similar, right? And treatment is sometimes overlapping. Sometimes clinicians are splitters. Is it this one or is it this one? We really have to know. And I'm always open to grayness. Mm-hmm. Mm-hmm. So no, complement is a specific type of protein in the immune system. Okay, so you are right, it is a protein, and sometimes it can be low if you have low protein levels, but that's very rare. That would be if you have like liver problems and things like that. When we're talking about a person with a normal functioning liver, generally normal protein levels, if the complement levels are low, we're concerned about if there's lupus disease activity. So, okay.